Okay, we're still in emergency medicine. I'm still Asher Kormuth, and this next patient is a patient who has been nauseous and vomiting all day. 44-year-old business executive comes to the emergency department with complaints of severe nausea and vomiting over the past 12 hours. Okay? Something changed 12 hours ago. He had been under a great deal of pressure recently and had taken numerous over-the-counter cold preparations and acetaminophen around the clock for a severe upper respiratory tract infection. Now, you are more sophisticated than your parents and grandparents who say, yes, I'm taking some over-the-counter medication for a cold. When you're told that in a board question, that's always a code word for something that's going to give you the answer to the question. If they're not naming an over-the-counter medication, that's because they want you to stop and think about what it is that the patient is taking that they don't remember, that they can't give you the name of the pharmacologic compound. So to say to yourself, they're taking a cold medication. What is the patient taking? How might that impact on this patient? What are the over-the-counter cold remedies? I won't name them by brand here, but what are they? There is diphenhydramine. You guys I will name them by brand so you're familiar with what the patient might tell you. Benadryl. What other compounds might you be taking? Obviously aspirin, which comes in one of a billion different trade names. What else? Pseudoephedrine, okay, commonly used in the anti-allergy medications, all right? And now we actually have histamine antagonists that are over-the-counter, antihistamines in other words, for allergy. But for the most part, you need to know antihistamines, pseudoephedrine, aspirin, and acetaminophen, which is specifically told in this question, okay? Are there many other things in these compounds? Yes, but those are the common ones. Those are the things the boards want you to think about. He has had several emergency department visits for alcohol intoxication, including one episode of alcohol withdrawal. He is a chain smoker and has several glasses of wine with dinner each evening. So he's taken, I have to assume he's taken possibility of diphenhydramine, aspirin, pseudoephedrine, acetaminophen, and alcohol. He has a very low-grade temperature. Blood pressure is okay. Pulse is a little fast. Respiratory rate's okay. Physical exam is normal except for mild right upper quadrant tenderness without rebound or guarding. What am I worried about in this fellow? Nausea and vomiting. Well, maybe he just has, could this man have an aspirin overdose? He can. Nausea and vomiting is pretty nonspecific. But in his case, it sounds severe. We're told it's severe, and it's acute in onset. And of the other things we overdosed on, what is likely to cause nausea, vomiting? Again, they're nonspecific, but in his case, they're severe. And right upper quadrant. Well, what lives in the right upper quadrant? The liver. So what hepatotoxin has he ingested for sure? Acetaminophen and alcohol. All right? Now, that combination is very important because let's say you take a history and he only took let's say acetaminophen extra strength, which is, I think, 500 milligrams. Let's say he's just taken, 2 of those every 3 hours for the last, day. He could have taken 5, 6, 7 grams or so, right? Not a huge dose. We might have taken that much. We don't end up in fulminant hepatic failure and die. But we're not taking those doses of acetaminophen, hopefully, with alcohol. Because the toxicity of alcohol on the liver with the toxicity of acetaminophen on the liver is very symbiotic, very synergistic, and you need smaller levels of acetaminophen to do much greater damage. All right? Another scenario where you might see the alcohol, Tylenol, acetaminophen combination is in a patient who you're told went out drinking. They're not a chronic drinker. There's no reason to think they have alcoholism in their history. Just tells you they went out to celebrate, had a couple of bottles of wine to celebrate passing the boards. In the morning they wake up, they got a terrible headache, and they say, headache, let me get some acetaminophen. They take 6 acetaminophen. Within the next 4 hours, a few hours later, still got the headache, they take some more acetaminophen. And then they develop symptoms like our patient. No chronic alcoholism, but again, that history of alcohol intake, and maybe not an enormous amount of alcohol, and acetaminophen, and maybe not an enormous amount of acetaminophen, and now they're developing symptoms. So that combination always in a question. Alcohol and acetaminophen should make you think of that combined toxicity on the liver, and it takes the form of acetaminophen overdose. Okay? Remember, that combination doesn't increase the likelihood of alcoholic hepatitis. It increases the risk of acetaminophen toxicity. Now, how do we evaluate a patient with suspected acetaminophen toxicity? What will we want to get on this patient? What's the most important blood test we're going to get? Well, already I told you, a blood test. Does this man need an immediate intravenous, by the way? No, he's not hemodynamically unstable. He might get quite sick quite quickly, but I'm not going to rush to put in an IV, get pulse oximetry, put an EKG on. I need to make a diagnosis. So what blood test is the most important blood test? Acetaminophen level, and acetaminophen level I need to interpret with what other information? How many hours is it since he took that acetaminophen? All right? I'm going to draw. I would draw a graph on the board, but then I have to step away from the podium, and I'm not wearing any pants. So let me explain. Just kidding. I'm going to draw a. In the old videos, I used to always stand behind the podium because I used to not wear clothes. But here, I'm fully dressed. So let me show you a diagram. If I take this is graph, I make this 0 time, let's say 2 hours, 4, 6, 8, 12, 24. And this is my acetaminophen level. Now, I'm making up levels just for argument's sake. And you'll read this off a nomogram, and you don't have to memorize what's a normal acetaminophen. They'll give you the nomogram. They'll give you the graph, and you'll have to interpret it perhaps. 100, 200, 3, 4, 5. Okay? Now, if I just took acetaminophen 3 hours ago, my level might look something like this. I took it, the curve would look something, well, if it's 3 hours ago, my level might be here, let's say. Okay? Now, is that normal or abnormal? I don't know. They would have to give me the nomogram. What's an appropriate acetaminophen level at 3 hours? You don't have to memorize it. You'll be told what's a normal level. And the curve probably looks something like this. By 4 hours, you probably stopped absorbing, and it's going to start coming down. All right? Let's say we'll take that, make the assumption that this is the normal acetaminophen absorption pattern. Okay? Now, if I get back an acetaminophen level of 250, okay, if the patient took their acetaminophen, say, 3 hours ago, 250, 3 hours, that's within the curve. That's normal. That's what it should be. If, on the other hand, the patient says, the last acetaminophen I took was 18 hours ago, 24 hours ago, and the level is plotted out here, at 24 hours, your acetaminophen level should be much lower than the 250. It should have fallen. So you can't interpret an acetaminophen level without knowing when the patient took it. All right? That's the information you need. The boards might make a question out of it. What additional questions would you ask the patient on a multiple choice question? What did you eat last night? When was the last time you saw your doctor? When was the last time you had a liver function test? Yada, yada, yada. When was the last dose of acetaminophen you took? And that's the key question. All right? And that allows you to interpret the nomogram in the appropriate way. Now, let's go back to our patient. And let's say I tell you that you get back a level that is, according to this question, 150, and that level is too high for the number of hours ago that the patient took the acetaminophen. Let's see, when they tell us when was the exact time you took it? No, but let's say it's 150 and it's 18 hours later, and let's say that number turns out to be above the level that he should have in his bloodstream. What do you do? So let's move on now. We talked about making the diagnosis, the clinical scenario, the synergy with alcohol toxicity, getting the blood level as the important first step, and then what do we do in terms of treatment? Well, first of all, if the patient says, or someone accompanying the patient says, yes, I just took the acetaminophen with the last 2 hours. I tried to kill myself. I took a bottle full of acetaminophen. I took 40 grams. I took 80 pills. What are you going to do? If it's in the first 2 hours, presumably some of those pills might still be in an area of the body that you can reach, namely the stomach. How could you reach it? Well, you could give the patient Ipecac and they could vomit it for you, or you could put down a nasogastric tube and try and lavage the stomach and get the acetaminophen out. Remember, in the stomach, things aren't absorbed yet, right? They get absorbed in the small bowel. You try and get as much out of the stomach as you can. In a practical way, we don't give Ipecac because if we give Ipecac, the patient starts vomiting for hours, and as you'll see in a moment, one of the medications we give for toxicity of acetaminophen is given orally. All right? The key drug for acetaminophen toxicity is given orally. So I don't want the patient vomiting. So typically, if it's within a few hours, and that's the key, because whenever you have a Tylenol overdose on the boards, one of the choices will be, in terms of management, do a nasogastric lavage or give Ipecac. And the answer is wrong all the time unless it's within the first couple of hours. Okay? First couple of hours, try and the vernacular, what patients say is, yeah, I remember when I was a kid, I had to have my stomach pumped because I took too much Tylenol. When lay people say the word stomach pumped, we basically mean an NG lavage. Okay? When you read the newspaper, this person went in there, their stomach pumped, that's what they're doing. Okay? So, it's, let's say, a day later in this patient, we get back a level that's toxic. What do we do next? What's the therapy for this patient? N-acetylcysteine, mucomist. All right? And that will provide a substrate to prevent further toxicity in the liver. All right? And that will be used for a number of doses every 4 hours going on over the next couple of days. Because the acetaminophen toxicity, first you get these kind of non-specific symptoms, nausea, vomiting, a little tenderness. Within 48 to 72 hours, though, the acetaminophen metabolites use up all the glutathione reductase in the liver, and then the toxic metabolites start to form, not to 48 to 72 hours later. So don't be fooled into thinking a patient who you think has acetaminophen overdose, if they have normal liver function tests within 8 or 12 hours, don't rule out the possibility of acetaminophen overdose. That patient might still develop fatal hepatic necrosis. You don't see the major LFT abnormalities, the major rise in transaminases, until 48 to 72 hours later. All right? So you're going to start the N-acetylcysteine, mucomist, and the other thing you're going to do is try and bind up, especially if it's within the last 12 hours or so, and there's maybe some acetaminophen still in the small bowel, I'll try and bind that up with a resin, namely charcoal. But the trick here is, if I'm giving N-acetylcysteine and I'm giving charcoal, not only can charcoal bind up my acetaminophen, it can bind up my N-acetylcysteine. So I have to try and dose them so that they're a couple hours apart. I'll give N-acetylcysteine, 2 hours later give the charcoal, then 2 hours after that give more N-acetylcysteine, etc. So you have to stagger the doses between the mucomist, the N-acetylcysteine, and the charcoal. Okay? And then you pray that you treated the patient before too much damage has been done. Let's say no matter how much N-acetylcysteine you give and charcoal you give, the patient came to you too late. They said, you know what, this happened 48 hours ago, I was very depressed, and I tried to kill myself, and here I am, I realized it was a mistake, and it's 48 hours later, I feel terrible, I feel weak, I've been vomiting for the last 2 days. You get a Tylenol level on them, the Tylenol level is 0. All right? But you get transaminase levels, and the SGPT, also known as the AST, and the ALT are sky high, they're in the thousands. But the acetaminophen level is 0. Does that mean we're talking about some other diagnosis? No, at 48 hours, I expect the acetaminophen level to be 0. And in fact, if the patient hasn't been treated, I expect the transaminases to be rising and rising. What do I need to do in that patient? Contact a liver transplant surgeon. Okay? That patient will die of fulminant hepatic necrosis with some reasonable chance. And if the patient gets better spontaneously, if they have starting to turn the corner and they've completed their episode of hepatic necrosis and the liver has this remarkable ability to start regenerating itself, then you don't need to transplant the liver. But if in the next 48 to 72 hours the patient becomes increasingly drowsy and encephalopathic and then develops a coagulopathy, that patient has fulminant not only necrosis but hepatic failure, and if that patient gets progressively worse, that patient will need a transplant. All right? And liver transplant obviously is not an experimental procedure, but again, you can't just snap your fingers and say, hand me the transplant. So you're going to think about a liver transplant early in someone who has full-blown acetaminophen toxicity. You'll hope the patient won't need it, but again, you have to get the process started. Okay? Now, how about the other possibilities in this particular case that we list in the differential diagnosis? Appendicitis, gastroenteritis, cholecystitis, pancreatitis, do any of them fit? Well, all of them can cause a sudden onset of nausea and vomiting. But appendicitis, we expect to see a fever, we expect to see nausea and vomiting, anorexia, Right lower quadrant pain. Can they have right upper quadrant pain? Sure, but that's not what's going on here. Acute gastroenteritis, a lot of nausea and vomiting, little tenderness, that's possible. But again, that's not my most likely diagnosis. Acute cholecystitis, patient doesn't have a fever, patient has tenderness, but I'll tell you the patient doesn't have a leukocytosis. Acute cholecystitis is unlikely. Acute pancreatitis from drinking, is that possible? Nausea, vomiting, 12 hours? Well, I'd like to hear some evidence of pain radiating to the back. And again, I have a lot of information making me think here of acetaminophen toxicity. Can this patient have acute pancreatitis? And this whole story I'm telling you is all wrong. If I had gotten back a acetaminophen level at, say, 3 hours, that was, well, 3 hours is still a little early because the patient might still be absorbing. Let's say at 6 hours, the level is 50. So I say the patient doesn't have a toxic level. They have acute onset of nausea and vomiting and right upper quadrant pain. Can that be acute pancreatitis? It can, all right? But again, this question is making it clear to think about acetaminophen alcohol combined toxicity. Okay, we're going to move on to our next case. I'm wheezing and my lips are swollen. All right, right now already you know this is going to be a case of what? An asthmatic with collagen implants? What is this? This is obviously an allergic reaction to something, okay? 27-year-old woman comes to the emergency department complaining of wheezing and swelling of the lips. The symptoms began acutely just after eating a chicken and nut dish at a nearby Chinese restaurant. Anything there that makes you think of allergy? Nuts. Okay, most people aren't allergic to chicken. Can they be? Sure, they can be allergic to chicken. But peanuts are now become a national health hazard. And if you think I'm joking about it, many foods, you look at the wrapper and say no peanuts included. Or when you send your kid to a new school, they'll have a questionnaire. Is your child allergic to peanuts? Not because they serve peanuts, because everybody eats peanut butter and jelly sandwiches in school. They want to know if your kid is going to eat Sally's sandwich, is she going to have an anaphylactic reaction in school in second grade because she ate some peanut butter and jelly? All right? And there are many foods that have peanut substances as a base. So it's very important these days we're asking everybody about peanut allergy, especially in kids who don't have a history of it and don't know about it yet. Okay? So nuts certainly makes me think of allergic reaction these days, especially peanuts. You see a peanut butter and jelly sandwich on the exam, probably someone's about to have an allergic reaction. Okay? She also complains of tightness in her chest and mild difficulty breathing. Does that surprise you? No. She has no significant past medical history and is taking no medicines. Okay? So this is not part of an asthmatic or someone who's allergic to many different things. She had a similar episode a year ago after she had eaten some cookies at a friend's house. Oh, maybe there's some peanuts in those cookies. Vital signs. Temperature's okay. Blood pressure's okay. Pulse is fast. Respirations are fast. She appears anxious and in mild respiratory distress. She has diffuse facial erythema and swelling of the lips and tongue. There is no stridor. What is stridor? Well, we all know what wheezing is. It sounds like this when you listen to the lung. That's stridor. Excuse me, that's wheezing. You all recognize that. Stridor is basically wheezing of the upper airways. So it's a much coarser sound. And if I'm just talking, if you hear some audibly wheezing, that's not asthma. That's upper airway. Upper airway wheezing, audible wheezing like that, should suggest laryngospasm. Okay? Which is very different than a patient going, that sounds like someone who's struggling with asthma. Somebody has audible wheezing. That's laryngospasm. That patient might be dead in a few minutes unless you make the diagnosis and act very aggressively. Okay? One is bronchospasm, one is laryngospasm. Okay? You can die from either one, but obviously you could die a lot quicker from laryngospasm. Her heart has a regular rhythm and is tachycardic. There's diffuse bilateral wheezing on auscultation. Okay. So there is, throughout the tracheobronchial tree, all the way up to the upper airway, there is constriction. The remainder of the physical exam is unremarkable. So what do we think this is? I can't think of anything besides an acute anaphylaxis. Foreign body aspirations are now differential. We spoke about foreign bodies. Do we have any reason why this 27-year-old who hasn't lost consciousness should swallow something? Of course not. And does that give you swelling of the lips? No. Does that give you stridor? Yeah, if it gets stuck in your upper airway, it'll certainly give you stridor. Okay? If you eat something that breaks up, if you swallow something that breaks up and gets into your bronchial tree as well as your upper airway, yeah, you could have wheezing and upper airway obstruction. But again, this is not the picture of someone with a foreign body aspiration. Asthma shouldn't give you stridor. Pulmonary embolus doesn't give you stridor, doesn't give you wheezing, doesn't give you swelling of the lips. Obviously, asthma doesn't give you swelling of the facial erythema. This is a classic presentation of an allergic reaction. Now, let's be more specific than an allergic reaction. I would say this is an anaphylactic reaction. Anaphylactic defined as that allergy, that allergic reaction carried out to extreme extent. Namely, either laryngospasm or hypotension. All right? And again, there's a spectrum from someone who gets a little itchy and maybe a little swelling of the lips and tongue. And those people might call you up and say, I got a little tingling in my tongue, my lip feels a little numb and heavy. I just ate some peanuts, or I just took a pill for a medication for the first time. So those patients say, I can barely breathe. That patient, if they don't get help right away, is going to die. The first patient should probably just stop taking what they took to give them the little bit of tingling and their rash and their facial erythema, and probably get some treatment for allergy. What would be the first line treatment for someone with mild allergic symptoms? A little facial erythema, maybe a little lip swelling, no stridor. What would be the first line treatment? Diphenhydramine, an antihistamine. Because after all, these reactions that we're describing are IgE mediated, and mast cells are stimulated to release histamine. And what we've just described are histamine reactions. Histamine causes bronchoconstriction, smooth muscle constriction in the upper airway, and vasodilatation. Vasodilatation gives you the red swollen face, the red swollen lips, and the bronchoconstriction and smooth muscle contraction gives you the wheezing and the stridor. If I don't have stridor, then I'll probably just use diphenhydramine. A little wheezing, well, maybe I'll go an extra step beyond the diphenhydramine. And what would that be? Let's say our patient who has clear-cut evidence of stridor. What are we going to do after the diphenhydramine? We're going to do something that we will not often do, except if we have a life-threatening emergency, which is ask for epinephrine to be injected. We'll give 1 to 1,000 subcutaneous epinephrine injection, as often as every 15 minutes. All right? Now, do we do this lightly? No. In fact, there's very few situations where you're going to ask for epinephrine. Anaphylactic reaction is one of them. All right? Now, we used to, years ago, I don't mean in the 1920s, but in the 1980s, we were still using epinephrine as part of the routine management of asthma in adults. Now, that's disappeared because we so frequently would see significant tachyarrhythmias from even subcutaneous epinephrine. But in this case, this patient has stridor. This patient might have complete airway obstruction unless you do something right away that will reverse that smooth muscle contraction, and that's epinephrine. So we're going to start with, in terms of medication, diphenhydramine. In our patient who has some evidence of respiratory compromise, we're going to treat those things that are life-threatening first, obviously. So I'll put some oxygen on this patient. I'll give, and this patient already has stridor. I'm going to move straight to the epinephrine. One to 1,000 sub-Q, as often as every 15 minutes until the upper airway symptoms respond. I will also give diphenhydramine, but what do I want to check before I give diphenhydramine? I want to check the blood pressure. Remember, if the patient's anaphylactic, they could have so much vasodilatation from the histamine diffusely that they're hypotensive and in shock. Would I use diphenhydramine in a patient who's hypotensive? No. No, no, no. It will further drop the blood pressure. What does epinephrine do to the blood pressure? It increases it. Epinephrine for your hypotensive patient with an allergic reaction or your patient with upper airway obstruction. And then what is the slowest acting drug, but what will stay on board the longest to protect the patient in the hours going forward? IV steroids. Okay? Very important is to identify what the patient's inciting event was. This is a CCS case, and you cure the patient of their anaphylaxis. The patient is watched. You have to watch the patient then for a number of hours because you can have a delayed reaction, a second reaction, say up to 6 hours later. So you watch the patient in the emergency room, say, for 12 hours. And this is a CCS case. And you say, send the patient home. You will lose 5 points for sure. Because what have you not done? The famous counsel the patient. All right? You could almost always pick up a couple of points by saying, counsel the patient. All right? What comes up? When you hit counsel the patient, then you have a list about 500 things you could counsel the patient about. About sex, drugs, alcohol, bicycle helmets, seat belts, religion, smoking, clothing habits, toothpaste, everything. All right? What you're interested in here is counsel the patient, and they'll say about what? Dietary restrictions. What dietary restrictions? Specifically, this patient, I would suspect it's not the chicken, it's probably the peanuts. All right? What else should I counsel the patient? And you'll get points if you do this. You'll lose points if you avoid it, if you neglect to do it. Counsel the patient that they should recognize the symptoms of early allergic reactions. Pick up a point, maybe 3 points. How about instruct the patient to have at all times an epinephrine injection available? All right? We don't worry about that so much with peanuts because an adult can generally recognize when they're about to eat peanuts. But again, you could be surprised. You don't know everything that's in those candy bars, that's in what the chef is making in the kitchen. But especially if someone has an allergic reaction, an anaphylactic reaction, after another particular common kind of after another common kind of allergen. What am I talking about? Bee stings or other insect bites, because that is harder to prevent. You walk outside, a bee comes, bites you, you have a terrible reaction, you have this patient's reaction, you go to the hospital, they give you the appropriate treatment, oxygen, epinephrine, diphenhydramine if you're not hypotensive, and IV steroids, and they send you home. You send them home on the CCS, you will lose big points. Because the patient goes home, next week they walk out of the house, a bee bites them, and they die. All right? That patient should have been warned that this can happen again. Now that the patient is sensitized, it might be even more severe the next time. And that patient must have had instructions to have access to epinephrine. And there are things sold in all drugstores called an EpiPen, which is basically in a moment of distress, when you're struggling, you don't need to start drawing up epinephrine in a vial. This is a pre-packaged injector. You take it out, you stab yourself with it, and you got yourself your sub-Q epinephrine. All right? It's potentially life-saving. All right? So again, it's commercially available. If you're doing counseling, if you're doing a CCS case, and you have a patient with an anaphylactic reaction, the patient will be cured. They'll be ready to go home. The CCS computer may not allow you to go yet. They might keep provoking you to think about what else you need to do for the patient. You have to identify the allergen, counsel the patient about avoiding the allergen if possible, and getting access to epinephrine. Okay? Now, if all of this doesn't work, and if our patient gets progressively worse, then what are we going to do? Well, let's say progressively worse in terms of hypoxemia and worsening airway obstruction. What do you need to do? You need to intubate the patient. Would you intubate the patient rather sooner or rather later? Rather later? Well, you say later because that's a young patient, she'll probably get better. Wrong. Sooner rather than later. You'll never see options on the boards. Choice A, sooner rather than later. B, later rather than sooner. But I want you to think about it. Think about the pathophysiology. What's happening? This is increasing laryngospasm, increasing edema. All right? Now, if any of you have ever tried to intubate, you know that in the best of times, it's not the easiest thing to do. It can become virtually impossible or outright impossible to do a laryngeal intubation if the airway is closed. If the airway is closed, it's closed. Those vocal cords, instead of forming that nice V that you look for, inverted V that you look for, looks like this. There's no airway. And no matter how brilliant an anesthesiologist you have, they can get an endotracheal tube past an obstruction. And then what you're faced with is doing an emergency cricopharyngotomy, which is something you always like to avoid. All right? So these patients, if they're there with wheezing and stridor, and you're giving them oxygen, and they're getting worse, and you've already banged in the epinephrine, you've already given them their steroids, and the patient's not getting better, immediately call for intubation. All right? And if they say the anesthesiologist, now we're going several steps, but this is, again, something you can't afford to miss, and the board might expect you to know this even as a step 3 level. If they can't intubate, what do you do next? You ask to proceed with the cricopharyngotomy. because that's indicating that you recognize that this is not just a routine but difficult intubation. This is an impossible intubation because there's no airway that's patent to intubate. All right? So again, you want to intubate this patient sooner rather than later. And again, the outpatient counseling in terms of what to avoid is very important. Okay, we're going to do the next case. And it's an 18-year-old man fell to the ground while playing soccer and hit his head. All right? Soccer, a more sensible sport than rugby. Probably going to be a smaller injury than rugby. All right? A more sensible patient. He was unconscious for 2 minutes. Okay? That's worth noting. He's complaining of a headache but cannot recall the incident. Oh, amnesia. His friends state that after the time of the injury, he had difficulty walking, which improved by the time he arrived in the emergency department. Now, again, the question didn't specifically say that he had trouble walking because of hemiplegia or hemiparesis. After you lose consciousness and you come to and you're awake, you might still be a little bit groggy and a little sluggish. That might account for difficulty walking. Vital signs are afebrile, normal blood pressure, heart rate's on the fast side, and his respiratory rate is normal. He's alert now, he's oriented to time, person, and place. The mini mental examination is intact, and there are no neurologic deficits. So what are the possibilities here? Can I tell from this history if he has a concussion or a contusion? Which one? Can I tell? What is the difference? Well, what is a concussion? Concussion means you've had head trauma and you've had some loss of consciousness, sometimes associated with amnesia for the event and for some preceding time. Again, we talked about this on an earlier tape, retrograde amnesia. Okay? How about a concussion? What's the difference between a concussion and a contusion? A concussion, what I just described was a concussion. What's the difference between a concussion and a contusion? With a contusion, there's usually a longer loss of consciousness, often a longer period of retrograde amnesia, and because I can't tell just by the history who has a concussion, who has a contusion, a CAT scan is usually ordered, even if it looks like a mild concussion. We'll get a CAT scan to make sure there's no contusion or something even more severe. Because a contusion will show some abnormality, some brain parenchymal injury, often some blood mixed in with the regular brain parenchyma. But no hematoma, no collection, no pressure phenomenon, no shift phenomenon. All right? Once you have that, you're talking about a hematoma, whether it's subdural or epidural. So concussion, and again, these are clinical presentations upon which you'll have a pretty good idea, but a CAT scan will help you distinguish. A concussion will have a loss of consciousness, usually just for a few minutes, not hours. The patient recovers and becomes oriented and may have some element of retrograde amnesia. In a concussion, no focal findings. A contusion, usually there are no focal findings, but there might be subtle changes, and these are transient. A CAT scan in a contusion will show us some evidence of brain injury. Very different from the patient we had on an earlier case where there was evidence of focal neurologic deficits that were clear and severe, a hemiplegia or a hemiparesis. All right? Ipsilateral ocular motor nerve injury. We don't have that in this patient. This patient, by history, has either a contusion or a concussion, the concussion being even the more milder of those two. And a CAT scan will help distinguish those two. In either case, what we're going to do is observe the patient, all right, because sometimes you might not find focal neurologic deficits appear till later if the patient did in fact have a hematoma from a tear of a middle meningeal artery that's only happening slowly. So it might take several hours. So if a patient has a concussion, we generally don't say, okay, CAT scan's normal, it's 20 minutes since you got to the emergency room, we'll let you go home and come back if there's any problems. So we generally will watch them in the emergency room for a number of hours. Hematoma, again, we went through that whole approach in the algorithm to approach the patient with a hematoma in terms of determining whether there is a mass effect with increased intracranial pressure. That is clearly not the case here. In a concussion or a contusion, patient has retrograde amnesia. The degree of amnesia, the extent of that amnesia, how far back it goes, is often a sign of how severe the concussion or contusion was. And if they have some amnesia, typically what happens is their amnesia resolves with the more remote events that they've forgotten coming back first. And with time, they sort of fill in what happened up till the time of their injury. All right? So here's a straightforward case of a concussion. If you have a CAT scan that shows injury to the brain parenchyma, we'll call it a contusion. Okay, and again, your job is not complete with a negative CAT scan. We need to continue to follow the patient to see if there's any further neurological change. Most of this we discussed actually in our earlier case when we had the far more severe hematoma with increased intracranial pressure. Let's move on to the next case. And it's usually not a diagnostic dilemma. Patient comes in burned. They're burned. There's no question about that. The question is going to be one of management. So, we're moving on. Case 11. A man was trapped in a house fire for 20 minutes. When he was finally rescued, he was noted to be alert and breathing, but had extensive burns on his right arm and anterior chest. And you're always going to get that sort of anatomic description because that will determine how much fluids the patient will require. And you'll be asked to write the fluid orders for burn patients on step 3, particularly in the CCS. And we'll talk about how you determine body surface area burn in a moment. He is currently awake and alert with a patent airway and moving air without difficulty. Does that assure you that your patient has not sustained any kind of respiratory tract burn? No. I mean, it's promising. It's a good sign. But again, that doesn't rule out that possibility. There's some soot around his mouth. That, in fact, makes me think that there might be respiratory tract injury. But he is not hoarse. Vital signs are stable. There are extensive second and third degree burns along the entire right arm and anterior torso. There are also some scattered first degree burns over both lower extremities and back. Heart and lung examination are normal except for tachycardia. There is no wheezing and his abdomen is soft and non-tender. Now this question actually describes to you that they're first degree burns or second degree burns, but you really need to know what these burns are based upon the clinical description, because the question might say, is this patient have first degree, second degree, or third degree burns? So let's talk about this. What is a first degree burn? Yeah, bad sunburn. The epidermis is intact. It might be red, it might be swollen. Sensation is intact. All right? So it's red, swollen, intact sensation for sure. If any of you have ever been burned, even with a sunburn, can progress to a second degree. Extremely rarely do you get. You have to be real. You probably have to be drunk and fall asleep in the sun to get third degree burns from sunburn. I mean, you really have to be out there for a time with during high noon with a lot of sun exposure, and really most people can't sustain third degree burns unless they've fallen asleep and are unconscious from sunburn. Okay, but it's not hard to get second degree burns by sunburn. All right? Because you're out there, you don't notice the burn, you're out there, you're in the water, which you think makes you feel nice and cool, but you don't realize you're still getting the sun exposure. You haven't put on the appropriate skin protection, which is important not just for protecting burns, obviously, but also for reducing the risk of skin cancer, whether it's squamous or, more importantly, melanoma. All right, so second degree burns, yes, it'll be red and swollen, but also you're going to have some blistering, and even some exudate, usually a whitish exudate, fibrinous exudate, and usually the sensation is going to be intact. Usually the sensation is entirely intact. All right. The third degree burns are obviously the worst, and this is when there's actually your skin is cooked. All right, it's charred. It's leathery. It's clearly burned. You now have, besides epidermis injury, you have significant and severe dermal injury, and that is a charred, has a leathery look. Think of it as you're cooking your skin. These are obviously the most severe. All right, and we'll talk in terms of our approach to burn patients, what we need to do in terms of preventing infection, particularly in these patients who have severely compromised not only epidermis, but dermis. Now, let's talk about the rule of nines. and that will help you determine body surface area. And a lot of this has been covered in the surgical lecture, so I'm not going to belabor the discussion of burns too much. But if you have a patient, and the question, more likely than not, will not tell you if they have first degree, second degree, third degree, and they certainly won't tell you what percentage of their body has been burned. That is left to you to calculate. So the body, chest, arms, chest, legs. Okay? Face, how much? 9%. Arms, 9%. Chest, 18%. How about the back of the chest? Another 18. Legs, 18. Your legs are twice as big as your arms. 18 and 18. Your perineum, 1%. I don't know why we had to go looking for 1% in the perineum. I mean, when you're adding up some big numbers, 1% doesn't really add much. Just reminds you to look and how much that could hurt. So this is how you calculate the percent body surface area. So our patient had what? Face and arms. Had 18%. Not a huge burn. But again, it's not just the body surface area, but the extent of burns within each area. Okay. Now, what are we going to be concerned about in any patient who has burns? Well, we're going to talk about how to manage the patient, and you need to know that patients can die, obviously, of burns. What are they going to die of acutely? In other words, within the first 24, 48 hours, respiratory compromise, number one. Number two, carboxyhemoglobin poisoning, all right? They have what looks like, when you draw their blood, it doesn't look hypoxemic at all. It actually looks cherry red. It's very bright looking. The problem is carboxyhemoglobin does not carry oxygen. And, it carries oxygen, it does not release it to the tissues. Okay? So you have enough oxygen floating in, even if your respiratory status is intact, but you cannot deliver to tissues. All right? It's essentially the same thing as being unoxygenated, or the same thing as being extremely anemic, where there's not enough circulating blood at the tissue level. The other point that you need to be very concerned about, besides severe respiratory compromise initially and carboxyhemoglobin poisoning, carbon monoxide poisoning, is what? Hypovolemia. Remember, we have an intact epidermis to protect us from having insensible losses that are insurmountable. If you've lost the epidermis, if you lost a significant percentage of body surface area in burns, you become hypovolemic losses from this large amount of insensible losses, and that will get us to the point of the key in therapy is airway protection, making sure the patient's oxygenated, and supplying adequate volume intravenously. Okay? We'll talk about the formula in a minute, which is based upon the patient's weight and the patient's body surface area that's been burned. After the first day or two, when you've gotten over the episode of respiratory compromise, hopefully, carbon monoxide, carboxyhemoglobin, and hypovolemia, then you need to worry about what is the late causes of death? Infection. All right? Our barrier against the universe's infections is our skin. And with burn the skin, our ability to fight off infection from contact is obviously greatly diminished, and hematogenous seeding and bacteremia is very common and potentially fatal. And that will lead us to watch the surface that are burned very carefully and debride them where there is necrotic tissue. All right? So in general, the initial assessment, we want to look for respiratory compromise. We're going to look for soot around the nasal, around the nares, and the mouth. We're going to look for evidence of stridor and bronchospasm on exam. We're going to supply oxygen. Even before we have back our carboxyhemoglobin level, we give the patient oxygen. Because if the patient's had a significant burn, certainly if there's soot around the oral or nasal passages, I'm going to assume that there's some respiratory burn, and I could assume that the carboxyhemoglobin level is going to be elevated. So before I even get that back, I put 100% oxygen on the patient, because that reduces the half-life of carboxyhemoglobin, supplying 100% oxygen. Okay? Again, like in our anaphylactic patient, if these patients have evidence of respiratory compromise, you have to think about intubating the patient sooner rather than later. All right, because again, it's going to get very difficult when the airway edema increases to intubate the patient later. All right, so I'm going to think about that soon. As to tell me the carboxyhemoglobin level is high, there's evidence of stridor, significant hypoxemia. After I give the patient 100% oxygen, then I'm going to think very strongly about having that patient intubated. All right, and then we're going to give the patient intravenous fluids. Again, I say then, we're talking about a minute or two later. You've gotten 100% oxygen on the patient, you've done your physical assessment, you're sending off the carboxyhemoglobin as you're starting the intravenous and putting in the fluids. If you ask me, what do I do first? Send the carboxyhemoglobin or put in the intravenous, which would you rather do first? Intravenous, all right? Establish access, all right, which might be hard to do if there's diffuse burns. Fortunately, this guy's left arm should still be okay. And I'm going to start fluids. At what rate? 2 to 4 ml per kilogram timed, multiplied by the body surface area. And that should be given over the first 24 hours, and we're going to continue to monitor the patient very carefully. How do I know in a very practical, simple sense if I'm giving the patient adequate hydration? Urine output, very simple. If the patient's urine output is 10 cc's, 15 cc's an hour, I know I am not keeping up with sufficiently with my fluids. The patient has insensible losses that are too great. I need to increase the volume that I'm infusing every hour. All right? You want to maintain at least 30, preferably 50 cc's an hour to document that you have adequate circulating perfusion. Now, in terms of local care, which is not as immediate as guaranteeing oxygenation and hydration, is you're going to clean the areas very carefully and apply silver sulfadiazine to the areas that are burnt. What you need to do is look at any areas that look necrotic and have them carefully debrided. Okay, and again, at this point, as interns, you're not being asked to debride complex burns, but you need to recognize that advanced burns, third-degree burns, you need to have the surgeon come and do adequate debridement and do wound checks twice a day. All right, and you'll apply the silver sulfadiazine, and you're going to do the wound checks twice a day. Any evidence of necrotic tissue in your third-degree burns, you're going to have that debrided to reduce the risk of infection. Okay, we're not talking about just local infection. Remember, you lose the epidermal barrier, you're prone to hematogenous infection as well. Okay, again, in general, patients with burns, it's not a diagnostic issue. The issue is making sure the patient is safe initially with oxygenation and hydration, making sure that areas that are necrotic are debrided and prevent infection. Okay? Some of these patients will require skin grafting, etc., but that's not something you need to be worried about in the emergency room period in time. Okay, we're going to move on to our next and final case on this tape in the emergency room, and that is a patient who complains of swollen eyelids. And I could think of a long differential of swollen eyelids, facial edema, nephrotic syndrome, etc. But you read the question, it's clear that there's one specific reason this patient's eyes are swollen, and that is because this 40-year-old laboratory technician comes to the emergency department after he was splashed with an unknown chemical while working. He's complaining of swollen eyelids and red eyes. His pain is worsening and he has blurred vision. His eyelids are edematous and his conjunctiva are hyperemic, which means they're red. The limbus shows patchy, blanched areas with conjunctival sloughing, especially in the interpalpable area. And obviously this is not, again, a diagnostic dilemma. You're going to have this patient, you're told has had a chemical burn, and you need to know how to manage that in the acute setting. And this is a very straightforward approach. Most burns, well, on the board, you may or may not know what the patient was burned with in terms of whether it's acid or alkali. In fact, acid, you might think, is worse. Acid injury to the eye is usually not as severe in terms of long-standing damage as the alkali damage. The acid tends to be a more acute pain early on, but the alkali tends to be a more progressive form of injury to the eye. And what is the approach to the patient with burn in the eye? Well, in the physical, you're going to examine them carefully. You're often going to see, as in this patient, conjunctival redness. You'll see swollen eyelids as a response. And on the corneal exam, there could be sort of edema, that haziness that you'll see when you examine the patient. To get the best look, you're going to want to do fluorescein examination of the eyes with blue light after fluorescein staining, because this allows you a much better visualization in terms of the extent of corneal injury that might not be apparent on straightforward examination. Obviously, the first thing is you want to irrigate the eye with water. You might get a choice if a patient you're told specifically had an acid burn, or if a patient specifically had an alkali burn. One of the choices might be irrigate with the opposite. All right? In other words, I have an alkali, let me neutralize it with some acid. Pour a little hydrochloric acid down there. Or I have an acidic burn, let me put a little alkali. Alkali doesn't sound so damaging. You're going to cause a chemical reaction, more burn, bad thing. All right? You don't want to put anything in the eye that isn't isotonic. All right? So those will always be wrong choices. All right? Don't become a chemist in the eye. All right? You're going to put in a lot of saline. All right? The patient might not allow you. If there's that much pain, you need to first give them a little optic anesthesia. And you want to make sure that when they were splashed, that besides the liquid that they're making very clear is bothering them, that you invert the eyelids top and bottom and look to see if there's any other foreign material in the eyes that need to be more copiously irrigated. These patients, even without obvious source of infection, because there's an abrasion and there's impairment now of the integrity of the lining of the cornea, these patients should be on topical antibiotics. In other words, eye drops with antibiotics. This is not something that we generally will be treating with oral, or certainly not systemic antibiotics. If there's severe corneal abrasion, the patient will have a lot of pain, a lot of photophobia. You might consider putting an eye patch on the patient. That's not going to do anything acutely, obviously. The key is recognition that there might have been a burn, copious irrigation, check under the lids on top and bottom to make sure there's no residual foreign body that needs to be irrigated, and you're going to start a antibiotic in oral drop form. You'll never lose points for asking for the ophthalmologist to come see a patient, and in fact you will lose points if it's a CCS and you're comfortable on your own just irrigating the patient, writing a prescription without having the ophthalmologist come see the patient. In particular, you want to do the fluorescein, the examination with blue light after fluorescein staining. The ophthalmologist is usually in a far better position to do this accurately than the doctors in the emergency room. All right, so the approach to the ocular burn is very straightforward. Usually you have a history of the chemical exposure. Alkali injury is worse than acid injury. A lot of isotonic saline and antibiotics to prevent subsequent infection. And with that, we're going to finish our discussion of emergency medicine. Thank you.